Hello, and welcome to Medical Specialists Associates Educational Series on Topics in Critical Care Medicine. I'm Christopher Voss, MD, a Harvard and Stanford-trained board-certified anesthesiologist and critical care doctor. Today, I want to discuss a paradigm shift in the management of septic shock. The early initiation of vasopressors, sometimes even before administering significant amounts of fluids. This approach is gaining traction for its potential to improve outcomes in patients with septic shock. Let's dive into the science behind this strategy. Septic shock is characterized by profound circulatory, cellular, and metabolic abnormalities resulting in hypotension requiring vasopressors to maintain mean arterial pressure greater than or equal to 65 millimeters per mercury and serum lactate levels greater than 2 millimoles per liter despite adequate fluid resuscitation. This hemodynamic collapse necessitates prompt intervention to restore perfusion and prevent organ dysfunction. For decades, the Surviving Sepsis campaign has recommended early goal-directed therapy, emphasizing aggressive fluid resuscitation before initiating vasopressors. However, emerging evidence suggests that a one-size-fits-all approach to fluid therapy may exacerbate tissue edema, impair oxygen delivery, and delay the use of vasopressors, leading to poorer outcomes in select patient populations. The rationale for early vasopressor use lies in its ability to counteract vasoplegia and restore vascular tone, ensuring adequate perfusion pressure. Excessive fluid resuscitation, while initially beneficial, can lead to dilutional coagulopathy, intra-abdominal hypertension, and pulmonary edema, complicating patient recovery. Recent studies indicate that norepinephrine administered early, even prior to large-volume fluid boluses, helps maintain critical organ perfusion by preserving preload and afterload while avoiding the harmful effects of fluid overload. The CENSER trial was a randomized controlled trial by Permpikul et al., 2019, that demonstrated that initiating norepinephrine early in patients with septic shock reduced shock duration and improved lactate clearance. The Mayhoff et al. 2022 study highlighted that patients receiving early vasopressors required less total fluid and exhibited fewer complications, such as ARDS. A meta-analysis by Lamontagne et al. 2020 concluded that early norepinephrine use was associated with a trend toward reduced mortality, although further large-scale trials are needed to confirm these findings. Administering vasopressors early should be carefully tailored to each patient. Here's how you can incorporate this approach. 1. Insert a peripheral line. Peripheral norepinephrine is safe for short durations if central access is delayed. 2. Assess fluid responsiveness. Utilize tools such as passive leg raise tests and dynamic parameters. 3. Monitor closely. Target a MAP greater than or equal to 65 millimeters per mercury while observing for adverse events like arrhythmias or ischemia. Critics argue that early vasopressor use may mask hypovolemia and delay appropriate fluid resuscitation. However, studies suggest that combining early pressors with limited guided fluid resuscitation provides a balanced approach, optimizing perfusion without overloading the vasculature. Early vasopressor use represents a shift in our management of septic shock, one that prioritizes precision and minimizes harm. While further research is needed to refine this approach, current evidence supports its role in improving hemodynamic stability and reducing fluid overload complications. Let's continue to challenge old paradigms and strive for interventions that provide the best possible outcomes for our critically ill patients. To learn more about critical care medicine, please visit us on our website at www.medspecialists.net and subscribe to our YouTube channel.